Chapter 11, Capillary or Dermal Blood Specimen Collection. In this narrated PowerPoint, we're going to cover the indications for skin puncture, as well as reviewing the necessary labs that would be associated with capillary specimen collection, explain why the capillary blood from a skin puncture is different than blood taken by a venipuncture, identify the proper sites for performing a skin puncture procedure and explain why it's necessary, describe the procedure for a skin puncture, and also describe the purpose and procedure for making blood smears as characteristic of acceptable. So indications for skin puncture. Benefits is diminished risks of iatrogenic anemia, which is an induced anemia by drawing too much blood from one patient at a given time. Sharps injury, patient injury, less painful than venipuncture, less costly in terms of equipment and supplies. It is faster than a venipuncture and easy for self-monitoring diabetic patients. The reduction for Sharps injury, as shown here, is because a lot of the equipment for a skin puncture is a retractable lancet to where the Sharps retracts into the device, so less likelihood of the technician potentially sticking themselves. Reducing the risk of injury and complications for children and adults. So because of the amount of blood, there's less risk of anemia, cardiac arrest, hemorrhage, venous thrombosis, reflux, arteriospasm, and gangrene of the extremities. It reduces the risk of anemia because we're taking less blood from a patient at any given time. The other thing too that it helps reduce is hemorrhaging, because we don't go so deep into the skin to potentially hurt or nick an artery or nerve. Reducing risk of injury and complications for children and infants, damage to the tissue organs, infections, and injuries from restraining a child during the procedure. So because the skin puncture devices have a penetration recommended depth, there's less likely for damage to tissues, less likely for infection because it is generally a one stick and done procedure, and less likely for restraint because during these procedures, it's a lot easier to get a patient to comply because it's less invasive. So indications for skin puncture for adult patients: if the patient has burns, thrombotic tendencies, fragile veins, and geriatric or is obese. In your book, it talks about these on page 373. Save veins for therapy, home testing, and point of care testing. The other thing to keep in mind is the saving of veins for therapy is ideal for oncology patients. And the patients who have severe needle anxiety, this would also be an optimal procedure for them as well. Indications for skin puncture not recommended. This can also be found on page 373 in your textbook. When large amounts of blood is needed for testing, swollen area may dilute sample with intercellular fluids, patient is dehydrated or has poor circulation, coagulation studies or erythrocyte sedimentation rates are ordered due to dilution effects, and blood cultures are ordered due to possible skin contaminants. If a patient is dehydrated, they're going to be less likely to produce a blood drop. The other thing too, if they have poor peripheral circulation near the surface of the body, this could also cause us not to get enough quantities. So this would be another indication of when it is not recommended to do a skin puncture. Common laboratory tests would include blood smears for manual white blood cell differential, complete blood count, hemoglobin and hematocrit, electrolytes, neonatal blood gases and bilirubin, neonatal screening, or what's called a PKU, and point of care or home or self-testing glucose. Please be aware that neonatal blood gases and bilirubin, once collected, need to be protected from light. to maintain stability. So why is a capillary puncture so different than a venipuncture? This can be found, and it starts on page 373 and goes to 374 in your textbook. Blood from arterioles, blood from venules, and blood from capillaries. There's intracellular and interstitial tissue fluids. Arterial pressure is actually stronger than venous pressure, so the capillary blood has a slightly higher proportion of arterial blood in the mixture. Because it's coming from a fingertip, it has a mixture of all these. So it's something we got to keep in mind when we draw these particular samples, that we let our lab know that this is arterial blood, because the reference ranges for our lab results will change. So basic technique for collecting a capillary blood specimen, we're going to greet, assess, and identify the patient and position the patient for safety and comfort. Perform hand hygiene and gloving technique. These two procedures do not change between the capillary and venipuncture procedures. They're identical. We prepare supplies and micro collection devices. Figure 11.1 in your textbook kind of goes over in detail a flow chart collecting capillary blood specimens that I would like you to review. So we're going to check diet restrictions. Was the patient supposed to be fasting prior to this blood test? Were they supposed to abstain from certain types of food? Do they have a latex allergy or adhesive sensitivity? And likelihood of fainting. We're going to select a site, warm it if necessary, and you can use a heel warmer or a warming device. In addition, lowering the arm downward to allow gravity for blood to pool into the fingertips is also really beneficial. We're going to cleanse the site with isopropyl alcohol and open the sterile puncture device within view of the patient so they know that it's a clean device. You're going to perform the puncture and wipe away the first drop unless specified for point of care testing. It is really essential we get rid of that first drop because it is the most contaminated. We're going to obtain the specimen and apply gentle pressure to the wound using a clean gauze pad. If you review competency checklist 8 in your lab book, this is going to go over in detail how we collect the sample. We're going to gently massage the finger to obtain the sample. And we're going to gently do a squeeze and release to obtain large blood drops. We do not want to scrape the microtainer tube, as this could cause the blood cells to break apart. You're going to discard the lancet in the biohazard container as soon as possible. Label the specimen, prepare it for transport, and assure bleeding is stopped and thank the patient before leaving. Again, please reference in your textbook pages 376, which goes over in detail the preparation for skin puncture and supplies needed, as well as competency checklist 8 in your textbook. So supplies for skin puncture. Puncture devices come in a variety of styles, sizes, and depths. The puncture devices that use a needle or blade that goes vertically into the skin. The incision devices that make a small slice into the capillary bed. Please make note that when we go to draw on, if we look at page 379 in your text, figure 11/4, we want to puncture across the grooves, not with the grooves of the finger. And we ideally will use the third and fourth finger of the non-dominant hand. Supplies for skin puncture, we're going to have disposable gloves, warming pack, heating pads, towels for warming the site, sterile hypoallergenic bandages and gauze pads, sterile single-use retractable safety puncture device, and disinfectant pads as well. Supplies, some additional supplies we might have is glass microscope slides, diluting fluids, plastic micro collection tubes or plastic capillary tubes, lab requisition or labels, a marking pen, and a biohazard container. Please also reference table 11/1 recommended puncture sites based on patient's age. Again, this image is going to come directly from page 379. So the preferable sites is going to be the third or fourth finger. We want to put the puncture device of the non-dominant hand. The darkened curved areas represent the most suitable puncture site that avoids the risk of puncturing the bone or nail bed. Keep in mind that each patient is different and slight adjustments may be needed. Fingerprint grooves are often hard to see but visible. If the dermal puncture incision should be across the grooves instead of parallel to the grooves. So we go perpendicular to the fingerprint. This helps form rounded drops of blood. If the incision is parallel to the grooves, blood tends to run into them and it's harder to collect. Okay, we're going to puncture should be slightly off center, the thickest part of the finger. For infants less than 1 year old or neonates, the use of the lateral and medial plantar surface of the heel is ideal, and we will cover this more in chapter 13 of our textbook. Sites not recommended for venipuncture include the earlobe, possible interference with piercings, close proximity to the eyes, and anxiety for the patient. The other thing, central arch of the infant's heel, posterior curve of the heel due to risk of injury, tendons, cartilage, and bone. We don't want to cause what's called osteomyelitis, which is an infection of the bone if we were to penetrate the heel. Okay. Fingers of newborn or infants less than 1 year old due to risk of hitting the bone and causing infection. We will not use the fifth pinky finger, risk of hitting the bone, again, osteomyelitis, due to a thinner tissue. We will not use the thumb as it has a pulse. Index pointer finger often more sensitive or calloused, and the swollen, infected, or previously punctured sites. Accumulated fluid may contaminate the specimen and site may be bruised. Please reference the clinical alerts on page 380 as these are important. The following sites are not generally recommended for routine skin punctures, and then also following up on osteomyelitis and manual non-retractable lances are not recommended for acquiring capillary specimens. It also goes into more detail about cleansing the site. Again, continued sites not recommended for skin puncture. Fingers on the side of a mastectomy. Lymph node removal during the surgery may result in fluid buildup. Consult with a physician if it's a bilateral mastectomy. Generally, it doesn't matter the length of time. It could be 10 years, it could be 50 years. If it is a bilateral mastectomy, we do need it in order for a foot draw from the physician. We cannot use the big toe. There's no clinical significant scientific evidence that supports its use. Improving site selection, do not use fingers that are cold. Blood flow may not be abundant and make it very difficult to obtain the sample. We're going to warm the puncture site, increase arterial blood flow to the area, what's called arterialized capillary blood, as seen on page 380 in your textbook. There's commercially available heating packs, and apply warm towels 3 to 5 minutes or rinse hands in warm water. We're going to lower the arm to allow gravity to pull blood into the fingertips. These are all ways to help improve the site selection. We're going to cleanse the site with 70% isopropyl alcohol pads. Allow the site to air dry thoroughly. Alcohol can cause hemolysis and contaminant glucose determinations, cause a stinging sensation at the puncture site, and prevent round drops from forming, which could cause hemolysis or breaking apart of the red blood cells. Iodine preparations are not recommended for disinfecting the skin puncture sites because they falsely elevate potassium, phosphorus, or uric acid determinations. So acquiring capillary blood specimen, dermal, or skin puncture using a retractable safety device, this procedure is covered in detail on page 381, procedure 11/1, through page 385 in your textbook. We're going to choose a finger that is warm. Do not choose fingers that are cold, stagnatic, or swollen. Cleanse with 70% isopropyl alcohol pad and air dry. Remove the sterile puncture device from the packaging in front of your patient. As shown here, they're trying to select the site for skin puncture, we gently massage the finger to also get blood to start circulating to the fingertip. We'll clean with the alcohol pad. If we notice when we pull the alcohol pad up it's significantly dirty, we will clean the site again. With the other hand, we're going to position the puncture device on the site. Again, we want to be perpendicular to the fingerprints. We don't want to be parallel. We're going to activate the release mechanism on the retractable safety puncture device and hold it perpendicular to the finger surface of the third or fourth finger. You're going to orient the incision of the puncture across the fingerprint to generate a large blood drop. We're going to discard the puncture device immediately after use in the biohazard container. Gently squeeze the finger to expel the first drop. And we're going to wipe that drop away with gauze and collect the second drop of blood by touching it to the tip of the collection device or microtainer tube. So this image shows the technician wiping away that first drop of blood and squeezing to get that second drop. We want to do a gentle squeeze and release. Excessive milking could cause hemolysis. We're going to gently apply pressure to the finger once the procedure is done and our tube is filled. Hold the puncture site in a downward position to encourage the free flow of blood. And do not use excessive milking, massaging, or forceful scooping because it may result in excessive tissue fluid or hemolysis of the specimen. Each type of micro collection tube has a different tube and blood volume requirement. So please be aware of this. Gently invert tubes 10 times with additives to mix the blood with the additive and seal the micro collection tubes very carefully. It is essential when reviewing your collection procedure that you also follow up on notes for obtaining a high quality capillary specimen and avoiding redraws found on page 384. So when filling capillary tubes, do not allow air bubbles to enter the tubes because air can cause erroneous test results. Blood flow is better and air bubbles are less likely if the puncture site is held downward and gentle pressure is applied. We don't want to put our hand above our heart because it slows down blood flow. Blood smears can also be made from sequential drops of blood. Refer to procedure 11.2 in your textbook. And again, this is showing them putting the gauze on the puncture site, putting some pressure on the puncture site, and then we'll bandage the patient. After a specimen is collected, use a clean gauze pad and apply gentle pressure to the site until bleeding is stopped. Label the specimen or outside containers to prepare for transport. Again, being mindful to put that it is capillary blood that's being collected. Remove and dispose gloves in a biohazard container. Perform hand hygiene and ensure that bleeding is stopped. Thank the patient before leaving with specimens and all remaining supplies. Other considerations. We're going to use a safe single-use sterile retractable puncture device. Use the correct device for the patient. So for an adult, the depth should be 2 to 3 millimeters. For children and infants, the depth should be less than 2 millimeters or 2.0. We want to avoid excessive squeezing or milking of the fingers. We're not going to use a pediatric device for an adult or vice versa. Laser devices are available as skin puncture alternatives. In the home settings, patients may have a multi-use device, which is appropriate for them, but we cannot use that device in a lab setting. We're going to fill each tube to the correct fill volume, and mixing the specimen is key for a good specimen. Again, we invert it 10 times. So the order of draw. After the first drop is removed, if ordered, blood gases should be collected first in our order of draw. EDTA specimens for hematology tests, so a lavender top tube would come next. Other tubes with additives, and as seen in your textbook on page 386, it would go lithium heparin tubes, then it would go lithium heparin in gel for plasma separation. Gray top, SST gold would be next, and red non-additive tubes would be last. It is really essential that when collecting for capillary, we maintain our order of draw to produce an accurate sample. So blood smear slides for microscope analysis, we will be performing this in class. The procedure starts on page 386 and goes through page 389 for your review. Rationale: automated slide preparation systems are more efficient, consistent, and reliable. Manual blood smears are not used in all laboratories. It takes a lot of practice. It is now automated, but we do it manually to show you. It's used for confirmation, detecting abnormalities, or a backup method. Slides treated with specimen to distinguish white blood cell morphology and blood drop is thinned out on the slide. So it's really, really important. The most common use for this is when looking at the differential, which is a complete blood count with differential, which determines percentage of morphology of the white blood cells and assesses red blood cells and platelet morphology. Manual blood smears are not cells. Manual blood smears are not used in all laboratories because of the automated system. I apologize. The other thing, too, when we're looking at this is in Chapter 7, we talked about the 5 different white blood cell morphologies. Eosinophils, leukocytes. So that's what we're looking for when we do a smear. We're going to prepare oneself as directed in Procedure 11/1. Perform the finger puncture in the usual way, wiping the blood away. We can also use an EDTA tube for minimal exposure of blood or blood spills to also obtain the blood smear slide. You're going to put one small amount of drop of blood above the frosted end of the slide. You're going to use your spreader slide and have a approximately 30-degree angle. We do not want to press downward too hard. There will be a video on this as well. And we want to create a very thin smear of blood, creating what's called a feathered edge at the end. The feathered edge would be represented in this image right here. We're going to make sure to label the slides. We don't want to use slides with chips. And the other thing is we don't want to wait too long, so we don't want to put too much blood on there because it could dry out. The other thing, too, that we want to be aware of is that we don't want to have slides that are too short, too long, or have a lot of bubbles in it. So a feathered edge looks like bird tips of a feather. So we want to make sure that that's what we obtain to get the best sample possible. Again, please review this procedure, and it can be found in your lab book as well. So venous blood tests results different from capillary blood test results. Notation should be on the laboratory test results that the specimen was a capillary sample and on our test tube. The concentration of glucose is higher in capillary blood than in venous blood specimens. And the concentration of potassium, total protein, and calcium is lower in capillary blood than in venous blood because of the mixture of arterial blood, venous, capillary, and then the various tissue fluids. Microhematocrit can be collected directly into a capillary tube containing heparin. You're going to fill the tube at least 2/3 full and seal it one end as soon as it's filled. A sealant can be clay or commercially available covers, and be mindful of potential blood exposures. This can be found in your book on page 390. Hematology specimens, they're collected directly into tubes containing the anticoagulants disodium, dipotassium, or tripotassium ethylene diamine tetraacetate. We refer to it as K2-EDTA. It's the most common one we see in our test tubes. Hematology tests should not be collected in heparinized tubes unless the only test needed is a PCV. Blood pH and blood gas determinations. We're going to warm the site to increase arterial flow prior to collecting blood for pH and blood gases. A heparinized capillary tubes must not contain air bubbles. Exposure to air will affect the results, and quickly seal the specimen after inserting a magnetic mixing bar or a flea. Again, this can be found in 390 on your in your textbook. We do not want to cause hemolysis, which is the breaking apart of red blood cells. It is really, really essential. So this is just various degrees of hemolysis. This would be slight hemolysis, and then this would be gross hemolysis. This can be caused by excessive milking or squeezing of the fingers. This can also be caused by not allowing the alcohol to dry. This can also be caused by excessive mixing or aggregation of specimen tubes. So instead of doing a gentle inversion, you shake it. This can be found on page 390 in your clinical alerts. Increased in red blood cell fragility and high packed cell volume in newborns and infants. So it's also, too, we want to be mindful when we're doing a finger stick not to scrape the blood off the finger, because this can also cause this. It's basically a red tinge of the plasma or serum. Serum or plasma should be yellow, and in this it's shown as red. There are some future trends where we could test smaller, cheaper, faster, easier to analyze, more portable, and less invasive for patients. Phlebotomists still play a key role in the future of this technology. The other thing, too, that I want to stress is on page 390, in completing the patient interaction, there is a hypoallergenic adhesive bandage may be applied as needed or requested. Such bandages are not recommended for infants or young children because possibility of irritation and potential swallowing or aspiration of the bandage. So it's recommended in this age group that we just maintain pressure until the capillary bed closes. So keeping that in mind. The other thing, too, is that patients, after we collect a capillary specimen, may have bruising of the finger. This is common. Just something to kind of make note of. This concludes Chapter 11, Narrated PowerPoint. Please make sure to review the study questions, the case studies, and the actions and practice at the end of this chapter to prepare for Chapter 11's test later on this week. Also make note on page 394, the competency checklist for capillary blood collection and making blood smears for microscopic analysis, which are also in your lab book.